So now we're going to be talking about complications of IV therapy. So you need to be able to identify the different complications that we're going to talk about and know what to do if they occur. So the first one we're going to talk about is fluid overload. So this is the systemic complication, meaning it's not just, doesn't just happen to the extremity, it is, full body system complication. So what this is when there is a too large a volume of fluid infused. We have to be especially careful with patients who have heart failure or renal disease because they are not going to be able to get rid of fluid like a healthy individual would. So they are at higher risk for developing fluid overload. So it's important to know signs and symptoms of fluid overload. So we have increased circulatory fluid, more than the body can handle and get rid of. So complications of that, you will see an increase in blood pressure because there are increased volume in the circulation. You can hear moist crackles in the lungs because this has caused fluid to back up into the lungs. So the lungs will sound wet. The patient might have cough with rapid and shallow breaths. They could become restless. They'll have distended neck veins, and then they could have edema, or likely will have edema, and in turn weight gain from that. So make sure that you can identify the signs and symptoms of fluid overload. This can be very, very serious because it makes it hard for the person's heart to work. It makes it hard for them to breathe. So this could be fatal even in some cases. So if we do recognize that this happens, then what we will need to do is decrease the rate of the IV fluid or just stop it until we've actually corrected the fluid overload. We need to monitor the vital signs, so specifically the blood pressure and the respiratory rate. Those are going to be our main ones that we're going to focus on, but we'll check them all. Also want to monitor our O2 saturation because if our lungs start filling up with fluid, we're not going to be able to have that gas exchange, so the patient's not going to be able to oxygenate. And then we're going to put them in high Fowler's position just to try to help promote good breathing as much as we can. One thing that we might anticipate being ordered is once we realize that this has happened, we need to let the doctor know or the provider know, and usually they will order some diuretics to help remove that fluid from the body. So make sure that you're following those orders correctly. And then after we have corrected the fluid overload, then we can make sure that we adjust the rate so that this doesn't happen again. You may also see some neurologic changes, so changes in the level of consciousness, confusion, headache, and even seizures. So just please be mindful of those things and notice those changes with your patient. Okay, another systemic complication is an air embolism. So this is pretty rare, but it's very important to realize how to prevent this from happening and the signs and symptoms of this complication if they do occur. So signs and symptoms of an air embolism are palpitations, dyspnea, or excessive coughing. They could also have an altered mental status, and they may have some shock symptoms such as weakness or a rapid pulse. So a venous air embolism is a consequence of air being introduced into the venous circulation, traveling to the right heart and lodging in the pulmonary circulation. So it's important to remember that small amounts of air can be removed from the pulmonary vascular bed by gas diffusion across the arteriolar wall and into the alveolar spaces. However, when the capacity of the lung to remove gas is exceeded, this is usually 50 mils of air or more, pulmonary outflow tract obstruction will occur. So really, it's got to be quite a bit of air in order to cause an embolism, but we don't want to risk it. So you never know. Every patient's a little bit different. Some patients are more sensitive to complications. So we just want to do our very best to prevent any complications. If this does happen, we want to clamp the cannula. So we want to stop the IV fluid, whatever is running that could be pushing that air in. Then we're going to put them in left-sided Trendelenburg. This is going to help kind of with where the pulmonary embolism is. So if it's in the lungs, if we lay in Trendelenburg, ideally it's going to go away from the lungs. Of course, we're going to check our vital signs and our oxygen. We're going to start them on some oxygen if they're not already on it, and then we're going to monitor them very closely. Okay, so another systemic complication is, of course, infection. So we've talked about with IV medications and IV fluids that the patient is at higher risk for getting an infection because we are introducing medications and things right into the venous circulation. So they have a higher risk for developing an infection. So for systemic complications, so think of what we look at for people who have a systemic infection. They're going to have a temperature elevation. They may have an increased pulse and respiratory rate. They may develop nausea, vomiting, diarrhea, and general weakness. So ultimately for this, prevention is key. So maintaining aseptic technique anytime we are doing something with an IV or IV fluids. And once we notice those signs and symptoms, we're going to call the physician for further orders, likely get them started on some antibiotics. Okay, so now we're going to talk about some more of the localized complications that can happen from IV therapy. So there's kind of two complications that occur from medication escaping into the tissue. So you can see here on your left here, we've got the IV Cathlon that's going through the vein. So it's no longer in the vein, and so therefore the medication or the fluid is going out into the tissue. You can see over here on the right side, it looks like there's a clot that's formed here, and so therefore that fluid is backing up outside of the vein and getting into the tissues. So you can try to prevent this by just making sure you're inserting the IV appropriately. But sometimes, complications happen, and so we need to know how to spot this and what to do. So the two complications that we're going to talk about that can happen from the fluid or the medication escaping into the surrounding tissue of the vein is called infiltration and extravasation. So infiltration, this is when you have leakage of a non-vesicant solution. So the difference between infiltration and the extravasation is the type of medication that has escaped into the tissue. So a vesicant is something that causes tissue damage. So a non-vesicant is something that doesn't cause tissue damage. So infiltration is when a non-vesicant leaks out into the surrounding tissue. So this is still a complication that needs to be dealt with, but it doesn't cause that tissue damage that a vesicant medication would cause. This is caused by, again, a dislodged needle or one that's penetrated through the vessel wall. So signs and symptoms of this are going to be edema because we've got fluids that are into that tissue causing swelling. They may have some leakage even, what we call like weeping edema. They're going to have some discomfort, and this is going to be cool to touch because it's those IV solution fluids or whatever it might be. It's going to be cool to touch. So what we need to do in this situation when we notice that this has happened is we're going to stop the infusion and discontinue the IV in that site because it's no longer good. We're no longer in the vein, or at least staying in the vein. And then we're going to apply warm compresses to the area. This is going to kind of just help reabsorb that fluid in the area. and then elevate the extremity to help aid in the drainage of that edema from the site. Okay, and then extravasation is ultimately the same thing as infiltration, but it is a vesicant medication. A lot of times, if the patient is getting a vesicant medication, they like it to go through a central line, so it's less likely for this complication to happen. So, like in the ICU, Levophed is a common vasopressor that's given, and it should always be given through a central line. Sometimes in emergency situations, it's given in a peripheral IV, but this is because it's a vesicant, and it can cause tissue breakdown and even necrosis of the tissue. That's just one example. There's several vesicant medications that we have to be very, very careful with. So if this extravasation occurs, you're going to see some blistering, inflammation, and even some necrosis. So again, with this, we're going to stop the infusion, discontinue the IV site, and make sure you go by the agency protocol and the manufacturer recommendations of the medication, whether you use a cold versus a warm compress. So, for example, if you use a warm compress, this is going to be something that dilutes and disperses the medication. Cold compresses are going to cause vasoconstriction, resulting in decreased blood flow and increased local reabsorption. So that's why we look at the manufacturer guidelines for, if this complication does happen, to know what's the best thing for our patient. And then, of course, we're going to let our physician know. Okay, another complication of IV therapy is phlebitis. So this is a local complication. What you'll see with this is a red, warm area, and they're going to have a painful vein. So phlebitis is just inflammation of the wall of the vein. It's caused from mechanical trauma from the needle or catheter, or it could be caused from chemical trauma from the solution that's being infused. So again, with this, we're going to DC the IV site, relocate the IV, and apply warm, moist compress to help with the discomfort of this and the inflammation. This is a phlebitis scale. So whenever you're charting on your IV sites, most facilities will ask for you to grade the phlebitis scale. So this is just kind of helps you to monitor the site, to document that you're looking at it, and to grade it if they do have phlebitis. So you can see here, grade 1 would just be erythema at the access site with or without pain. Grade 2 would be pain at the access site with erythema and or edema. 3 is pain at access site with erythema and or edema and streak formation. So you can see that in the last picture here. It kind of has streak formation. You can see kind of where the vein is and how inflamed it is. And then you may also have a palpable venous cord, so you can feel that inflammation in the vein. And then 4 would be pain at access site with erythema and or edema, streak formation, palpable venous cord greater than 1 inch in length, and purulent drainage. So this is really, really, really bad. Phlebitis. So phlebitis can be with or without an infection, but it could lead to an infection as well, or be caused from an infection. Okay, so our next complication is another local complication. This is thrombophlebitis. So this is similar to phlebitis, but it's caused from a blood clot in the vein. So the blood clot in the vein has formed, and it's causing inflammation. Again, this is caused by tissue trauma from the needle or the catheter. So we know anytime someone has trauma, they can be more likely to clot, the body's reaction to that trauma. So this is something that could happen. So signs and symptoms of this are going to be pain, redness, swelling, warm to touch, and they can develop fever or general malaise as well. So again, we're going to DC the IV. Apply a warm compress and elevate. And we're going to make sure that we do not massage that site because we do not want to dislodge that clot. Okay, and then another local complication is a hematoma. So this is bruising. So this can happen. Some people are more prone to developing hematomas if they are on anticoagulants. But we just want to be mindful that this probably means that they've got leakage from the venous site, and it's probably not in the vein. So what we're going to see is ecchymosis or bruising. They may have immediate swelling around the insertion site. So this therefore indicates that there's blood leakage. So we would need to remove the IV, apply light pressure to stop the bleeding, and then we could give them ice as needed for 24 hours and elevate. We're going to assess for damage to movement, circulation, and sensation. Okay, and then lastly, we're going to talk about clotting and obstruction. So this can happen within the IV tubing or at the end of the capillon. So if this does happen, you're probably going to be unable to flush. Your IV might quit running as fast as it should or quit running altogether. It may cause some blood backflow. So this means there's a clot somewhere. So the IV site is no longer good. We're going to discontinue the IV site. We're not going to try to pull out the blood clot, and we're never going to force flush because this is going to cause pushing clots into the bloodstream, and so we never want to do that. So in order to prevent this, we need to make sure that we are maintaining patency of the IV site. If we have fluids running, try not to keep them paused for too long. We can also run fluids, KVO. That stands for keep vein open. So just at a really low rate, but it's just making sure that you're keeping that IV site patent, keeping all that tubing patent, and making sure there's not any clots that are able to form. Now, of course, you have to assess, make sure there's no contraindications to this. So someone who's at risk for fluid overload, you wouldn't want to just start them on KVO fluids without consulting with the physician. But you can also flush your IV site. So at least once a shift, I would probably do it more often than that. You want to be checking the IV site, looking for any of these complications and making sure that you're flushing it to help keep it